Evening, everybody. I'm Ashley Ross. I'm a associate professor of urology here at Northwestern. I'm going to talk a little bit tonight about non-radical treatments for prostate cancer, focusing on subtotal gland treatments for the disease. A lot of the treatments I'm going to talk about are ablative treatments. There'll be another follow-up in August where I talk about use of some of these things in the salvage setting after radiation. So we'll start with a case presentation. This is a gentleman that I treated recently. His PSA was 7.1. He's a 74-year-old. On DRE was non-suspicious, and they got an MRI to understand what was going on better. And they saw a PIRATS 5 lesion in the right transition zone. You can see up there on the ADC that there's an area of suspicion on that upper right side, and down on the T2 signal, you can also see it as well. That was targeted, and that target biopsy showed a Gleason grade group 2 cancer, 3 + 4 = 7, 40% pattern 4 component involving 2 of the 3 cores. All the other cores were negative for cancer, including sextant systematic sampling. His past medical history was significant for an appendectomy. He's on chronic anticoagulation for atrial fibrillation, and he has obstructive sleep apnea. But his overall survival was estimated by the Social Security actuarial tables to be around 10 years, and he's still working and fairly active. He talked with his diagnosing urologist and wanted to proceed with treatment, and then he had consultations with both radiation oncology and other urologists, mostly regarding surgery and radiation. He additionally saw me and talked about a chance for focal therapy. He wasn't interested in radiotherapy. He worried about protracted bleeding episodes potentially with him being on anticoagulation. And he's also worried about surgical excision. So we took him to the operating room and elected to do a subtotal cryoablation. We ablated the right transition zone lesion and did a little bit of a hockey stick across to the left side, but sparing both neurovascular bundles and obviously not affecting the sphincter. He had an uneventful recovery. That was an outpatient procedure. We removed the catheter 7 days later. He had immediate continence, which was complete. He had no decline in his sexual dysfunction when I talked to him in clinic a few days ago, but he has ED at baseline. PSA was 7.1 before the cryoablation. It was 0.94 at 3 months out. And our plan is to continue PSA monitoring. We're going to do an MRI and a confirmatory biopsy at about 12 months. So the subject of this talk today or this evening is going to be about subtotal therapies for prostate cancer. We'll talk about the premise of doing that type of therapy, about patient selection and some considerations, about the selection of treatment and some treatment planning, and then we'll review some of the outcomes. So again, the premise is obviously the early diagnosis and treatment to cure of basically what is early stage prostate cancer will obviously optimize prostate cancer specific mortality, but because of the long natural history of prostate cancer, perhaps not overall survival. It's also important to note that whole gland therapies carry morbidity. Surveillance or active surveillance is firmly established as the preferred option for men with very low risk disease and some selected men with low risk prostate cancer, but it's not really that well studied or understood in high volume low risk disease or favorable intermediate risk men. And subtotal gland therapy can be a curative option in carefully selected men that could be done potentially with minimal morbidity. So let's unpack some of this premise a little bit. First, we'll talk about the what we already know, at least this group knows, that whole gland therapies, carry with them some morbidity, particularly sexual dysfunction and some urinary dysfunction. These are some outcomes from the comparative effectiveness study CAESAR published in Barakis and et al. In JAMA 2017, looking at people after radical prostatectomy or after radiation therapy or following surveillance. What we already know is that surgery can cause erectile dysfunction to a largest extent of the different therapies. There is some recovery, and men, not in this case not shown here, men with perfect function often fare better, but there is some sexual decline. This is just showing the metric of erection sufficient for intercourse. Radiation also causes a decline. Sexual surgery shown there in the blue, radiation in the purple, can also cause some decline. Men overall fare a little bit better than surgery if they are starting out with perfect function. active surveillance has the least effect on sexual function, but there is a decline over time as well. If we look at urinary leakage, then that can be also affected, particularly with surgical approaches. And what's not shown here is that radiation-based approaches can affect bowel function and also have some long-term side effects in the minority of men, including strictures, secondary malignancies, hemorrhagic cystitis, proctitis, etc. So, one approach is to say, well, what we could do to avoid these toxicities is we could take a lot of men and we can survey those men. And that way, as we saw on the previous slide, they can stay on that green line relatively stable over time. And indeed, active surveillance is and should be the standard of care for men with very low risk prostate cancer. So those are, men with less than 50% involvement of a core, 2 cores or less from a 12-core biopsy, and only Gleason grade group 1, only T1C. This is long-term data from the Johns Hopkins series, which is primarily those men and some carefully selected low-risk men. And it shows you that the cumulative hazard for death was basically flat over time. That's the yellow line. Whereas the dotted blue line shows death from any cause, obviously occurring among this population. And in fact, if we take a bunch of different series of men with very low risk or minimal volume, low risk disease who choose surveillance up front and do some modeling, we see that their treatment-free interval is about 6.5 years, with them only having a chance of increased mortality projected to be about 2 months. And, some guidelines and panels and other experts will sometimes say, well, actually surveillance should be the treatment of choice, not just for very low risk disease, but for low-risk disease as well. And some people will also extend out to say it should be an option for favorable intermediate-risk prostate cancer. I think for this population, we really should say active surveillance could be considered, but we have to really be aware, particularly of the large selection biases that went into both well-done surveillance prospective registry trials like the Hopkins study and the one from Memorial Sloan Kettering, but also into the randomized control trials, including trials like PROTECT, which we'll talk about in a second. And so for men with low risk prostate cancer or favorable intermediate risk prostate cancer, yes, they can consider surveillance, but we have to be aware of a few things. One, that the outcomes for men with higher volume, low risk and favorable intermediate risk prostate cancer are, in a large extent unknown, and we'll go into that data in a second. That the progression to treatment within 3 years for these men is going to be substantially greater than men with very low risk or those with marginally low risk cancer. That many men with deferred treatment who start out at high volume, low risk or favorable intermediate risk disease will progress to unfavorable intermediate risk disease. And when they get treatment, they're going to require treatment with treatment intensification, whether that be less nerve sparing at the time of surgery, or whether it be the addition of short-term androgen deprivation therapy to radiation treatment. Few, but some men with deferred treatment that are starting out with this higher volume, low risk or favorable intermediate risk will progress to locally advanced disease, and even less, but some to metastatic disease. And obviously that's an undesirable outcome. So let's just look at some of that data before we go forward, because I think it's important and I think often misquoted. So first, men with low risk cancer as compared to very low risk cancer, even in surveillance series where they've been selected, are much more likely to be reclassified to higher grade disease. This in the middle, you see a Kaplan-Meier curves of the Johns Hopkins surveillance series, comparing carefully selected low risk men to very low risk men. And this is the hazard ratio for reclassification to Gleason grade group 2 disease or higher. And when you compare those two groups, the hazard ratio is about 2.4. And you can see the blue line being the low risk men, the red line being men that are very low risk. Now, that becomes even more striking when you look at the fact that men in the active surveillance population, so low-risk men in the active surveillance population, are often not indicative of your run-of-the-mill low-risk patient. If we ask, well, among men that had a 12-core biopsy, how many men with Gleason grade group 1 low-risk prostate cancer had more than 4 cores or 4 cores involved by their disease, so more than a fourth of their biopsy cores positive. In the Hopkins active surveillance series, among the low-risk men, only 8% had that kind of, let's call that high-volume, low-risk disease. Whereas if we look at the people at Hopkins during during the same period that underwent radical prostatectomy, it was about 50% that had 4 or more cores involved. If we look at the recently published series from Memorial Sloan Kettering on their surveillance cohorts, which I think was thousands of men, I think it was 3,000 men, the median number of biopsy cores involved with cancer was 1. And so really there's an underrepresented representation of high volume, low risk disease. Moreover, if you look at favorable intermediate risk prostate cancer in all the series presented, they're also underrepresented. Less than 15% of the men in all those series are favorable intermediate risk disease, and we know that their outcomes are less favorable. On the right here, we can see the men from the Gothenburg trial for prostate cancer screening, so PSA screened men that went on surveillance, and you can see the Kaplan-Meier estimates for progression to treatment. The blue line being very low risk men, and then low and intermediate risk men, of which almost all were favorable intermediate risk men, shown there in the orange and the green. More so, it's certainly true that there is clinical progression for stage 1 and 2 prostate cancer on surveillance. This is the most recent update of the PROTECT trial. And the PROTECT trial obviously was a randomized controlled trial with all PSA screening detected prostate cancers. Majority of patients being low risk and favorable intermediate risk. And they followed them over time. It wasn't active surveillance, which is sometimes a criticism, but it was active monitoring. And that active monitoring in this trial actually somewhat represents, I think, a lot of the surveillance that happens in the community settings and in unstructured clinics. Here, when they're looking at progression, they're looking at real deal progression. So progression to clinical T3 or T4 disease, initiation of ADT, locally advanced disease causing rectal fistulas or needing chronic catheterization, ureteric obstruction, or obviously metastatic progression. And what you can see in the Kaplan-Meier curves in the upper right, when followed for over 10 years, and people with active monitoring, even if they're low or favorable intermediate, do have that kind of substantial progression. And if you look at the upper left, that's your Gleason score 6 patients on active monitoring with about a 20% chance of this sort of clinical progression to locally advanced or metastatic disease at 10 years. And if you look at the Gleason 7 folks that are followed, then obviously it's much higher. So there is a need, and particularly in these I think high volume and favorable intermediate risk patients, we want to detect those people. I think a lot of those men that have a 10-year survival, we're going to want to treat them to cure, but we're going to want to do it in a way that can minimize some of the morbidity of whole gland treatment, so that in a way that can maybe be away from the neurovascular bundles, not affect their urinary control. And several years ago, there was just a survey sent to urologists, and about 70% of the urologists thought that focal therapy would become a standard option. We've seen CPT codes now given to HIFU. We're seeing new types of modalities of therapies being presented essentially, throughout the last few years. And I think this is really coming more and more into the mainstream practice. And so, as we move to say, okay, that's the premise of it. So let's talk about what probably is the most important thing for implementation, which is really patient selection. So who are we going to pick if we're going to try focal therapy, and particularly if we're going to be doing this, where we only have intermediate or short-term outcome data available? So obviously, we're going to pick people that need to be treated for their cancer. So just like for anyone with clinically localized disease who we're thinking about treatments, they should have an adequate life expectancy. So a life expectancy of 10 years or greater. The patient should be willing and able to either undergo an MRI, which is the way that most patients are selected and biopsied for consideration of subtotal glandular therapy, or they could consider a saturation biopsy. The men have to be, in my opinion, willing to undergo confirmatory biopsy, even though in my case example, I showed you a gentleman where we did a subtotal glandular therapy and he had a dramatic improvement in his PSA. Those fluctuations in PSA are fairly unreliable and haven't been well validated in the follow-up setting. They have to be willing to undergo a confirmatory biopsy to assess cure. They have to have very low chance of lymph node involvement, because obviously you're not going to treat with the focal therapy. You're not going to be treating a disease in the pelvis, and so I think this confines us to low and favorable intermediate risk prostate cancer. There's some small series that have looked at unfavorable intermediate risk disease and even high risk disease, but I think the real sweet spot is probably the favorable intermediate risk men and some of the high volume, low risk men, provided that their disease is localized to one area of the prostate. Unilateral lesions obviously would be preferred. I think that the ideal candidates are people with, not only unilateral lesions, but lesions that are more anterior, as that allows for sparing of the neurovascular bundle. And finally, we want to select patients that are unlikely to develop new prostate cancers. And this gets into the idea of like the seed versus the soil. Did this gentleman develop a prostate cancer because there were some cells that acquired some mutations that drove that to become cancer, and that cancer then grew out? Or is this someone who's likely to sprout a contralateral cancer, or other multifocal disease due to either their genetics or some other factors? So again, let's unpack a little bit of this, or at least refine our understanding when we go about patient selection. One thing that definitely needs to be validated, and certainly is kind of I think forward thinking, is this idea that I just mentioned of seed versus the soil. So what we probably don't want to select for focal therapy is a patient who's going to develop or has multifocal disease, or someone who has a higher propensity of developing more prostate cancers. And in that regard, we can say men with rare pathogenic mutations, like things like BRCA2, are unlikely to be good candidates in my mind for focal therapies. We know that those men, even though they're the minority of men, have much more chance of being diagnosed with prostate cancer, being diagnosed with aggressive prostate cancer, and of progressing, on surveillance. On the upper right there, you can see a study from the UK Biobank showing progression among rare pathogenic mutations in genes like BRCA2, causing that more diagnosis of prostate cancer in those individuals. The second thing that's been emerging is, we've seen in the last several months the Practical Consortium publishing some of their polygenic risk scores or polygenic hazard scores. We have another group, led by Dr. Zhu and others, who have published their genetic risk score, also looking at the UK Biobank. The Ambry Genetics has also published or have used a polygenic risk score. This more recent polygenic risk score published by Zhu and colleagues, is shown here on the right as their genetic risk score, or GRS, actually is a clinically available test out of their lab called GoPath, and that looks at multiple SNPs, and people in the highest quartile can have a much higher propensity of developing prostate cancer when you look at large series like the UK Biobank series. And so there is one question here, is that if someone has those types of genetics, they're at a high risk of developing prostate cancer early in life. And actually, what Zhu and colleagues showed in the recent publication in the prostate is that in fact they can get they can have more likely to have multifocal disease. They may also be poor candidates for something like focal therapy. Moreover, when you do your treatment planning, I think what is kind of well established, while we have to still establish some of those genetic biomarkers, what is well established is that MRI is going to underestimate your tumor size. So tumor extent can be underestimated by MRI in more than 2/3 of the cases. And the reality is that when we think about our focal therapy planning, your treatment zone, I think, should usually be up to a centimeter around the your lesion of interest on MRI. At least I would say at least half of that. And this is just some examples using whole mount and then looking at comparisons to MRIs. It's also important to note that MRI fails to detect lesions as well. Almost 16% of at least in grade group 2 to 5 lesions can be missed by MRI. So it's important that if you're selecting a person for focal therapy, they've had not just region of interest sampling, but also have had systematic sampling as well. There's a paucity of studies that link Gleason grade group with imaging characteristics. We don't really know what makes things more likely to be missed on MRI. I think that next steps is to understand imaging a little bit better, maybe using some artificial intelligence training there. And also a more early next step is to bring in PET imaging. PET PSMA, which is nearing FDA approval kind of nationwide, and obviously already approved in California in some settings and then used in other countries, is a good way to actually image localized prostate cancer. Roughly 90% of the studies published can show that you can detect localized prostate cancer by the PET imaging. And you might say, well, most of those people used higher volume, higher grade disease, obviously like this disease that we're looking at on the PET MR in front of us. But if you look at even some favorable grade cancers, and you ask like, well, were we able to see them on PET? You can, and actually PET MR may have the best sensitivity for detecting Gleason grade group 2 or 3 lesions. This is a relatively small study, but it looked at PET MR, and it found that the sensitivity, if you use PET or PI-RADS of 3 to 5, was going to be about 94%. And a lot of that sensitivity, if you look at that upper box, a lot of that sensitivity is actually being driven by the PET PSMA. So there are some soon to be starting clinical trials here at Northwestern looking at PET PSMA in lots of settings, including the early grade disease setting. And I think that this is a promising area that can help with treatment selection for focal therapy. So say now you've selected your individual. The individual has a 10-year or more life expectancy. It's an individual with, say, unilateral disease, preferably away from the neurovascular bundles on both sides. There's an individual that agrees that they can that they'll be followed to maintain that they've been cured with a subsequent biopsy. Maybe you've been even a little bit ahead of the curve, and you've done some genetic testing, and you said, well, neither do they have rare pathogenic mutations, nor do they have a high polygenic risk score. Here's going to be my candidate. Now the question is, what modality do you use? And one unfortunate thing is that there's I think more effort has gone into the development of different modalities to ablate prostate tissue than into understanding who is the best candidate and what are our long-term outcomes. But that said, there's multiple modalities that are available. There's some that are in higher clinical utilization, namely cryoablation of the prostate and high intensity focused ultrasound. Both of those have CPT codes, and some insurances are allowing for coverage. There's other things that have been studied, like focal laser ablation, irreversible electroporation, vascular photodynamic therapy, and focal radiation. In all cases, there's a variance in the abundance of available data for both their safety and efficacy, but also there's issues with their availability of use and what you do if you need to do retreatment. So we'll look at a little bit of the outcomes data just to make a couple highlighted points. First is that, again, a lot of our interpretation of the data is going to be limited by the fact that most of this comes from retrospective studies, and in those cases, the patients might be highly selected. And as I pointed out, even in randomized control trials, there is still a selection bias in which patients get into those. And there's variability in the follow-up protocols and reporting. But this was a nice kind of summary by Venderpool and others in European Urology a few years ago. There's some other good reviews out there too. And you can see a couple things. One is that for all of these therapies, rates of incontinence with focal therapy is low, and rates of erectile dysfunction are low. Second thing you can see is that the follow-up range is really, you're talking about short to intermediate range follow-up, from as little in some of the studies of weeks to 6 months to, average follow-ups of maybe up to 5 years. What's not really shown here is that, when we look at the oncological outcomes and biopsy positivity, we can say, well, why are some of the treatments different than others? I think that what's hidden in this data is the fact that true focal therapy is unlikely to work. And that's kind of an extrapolation of what I showed you at the MRI underestimating the size of these lesions, that the even if there is one index tumor, it's often bigger than what you're seeing on imaging. And the failure rates when true focal therapy has been employed have been in many cases, in my opinion, unacceptable. So let's talk about some of the focal therapies that are in a little bit more wide use. This is cryoablation, like the case example I showed. It's probably the most extensively used among the ablative therapies, FDA approved for salvage radiation, and it does salvage radiation failures, and it does ablate prostate and prostate cancer tissue. The idea here is you have the person in either an outpatient setting, or I've seen some practitioners in some settings do this focal therapy with the patient awake in their clinic. You're going to use ultrasound guidance, and you'll place through the perineum these different freezing rods. I like the Healthtronics system because, as you notice in that middle picture, there's a slider, and that slider that allows you to control the size of the ice ball. Now, obviously, periurethral tumors are going to be spared by this type of therapy because you have a warming catheter in the urethra protecting the sphincter, and that's going to spare these periurethral tumors. And so that has to go into your treatment selection. When you select these patients appropriately, you can get pretty decent outcomes. They've only been published in systematic ways, I think, in the short or intermediate term. In the middle, you see a study by Shaw et al., and this is looking at NCCN intermediate and high-risk patients. The black line being the intermediate risk patients and the orange line being high-risk patients. I don't think high-risk patients are ideal candidates for focal therapy, but you can see with their kind of short follow-up time of 36 months that there was about 80% of the intermediate risk patients were free from any subsequent therapy or from progression to locally advanced or metastatic disease. On the right, even a smaller trial, 61 patients, but a really well done study. This is an update of a study led by Dr. Marks at UCLA, and they were looking at primarily Gleason grade group 2 and above cancers, so clinically significant cancers undergoing hemiablation with cryotherapy, and they were following them at biopsies at 6 months. They were biopsying the target lesions, and then again at 18 months where they did extensive systematic sampling and sampling of the target lesions. And what they found was about 80% are free from recurrence in that study. Again, kind of a short to interim follow-up, but very promising. They had excellent functional outcomes in both of these studies, with basically 100% continence and a fairly good preservation of sexual function. HIFU is another commonly used way of doing focal or subtotal gland ablation. It's been fairly extensively used. It's just recently got a CPT code. Traditionally, HIFU was done with a transrectal approach. You're sending those high-frequency ultrasound waves to the prostate lesion. Because it's ultrasound, as you can imagine, there can be limitations to gland size, and particularly anterior tumors that can be hard to target with the HIFU, and the gland can sort of expand also and move away from you during the treatment as well. Secondarily, men with a lot of prostatic calcifications or large calcifications, those can disrupt the HIFU beam as well, and that can lead to inadequate treatment. On the right there is the 5-year outcomes of a UK HIFU registry that had several hundred men, almost 600 men on that trial, and it was following those men, including ones with Gleason scores of 7 or 8 to 10, and also those with Gleason scores of 6. And what you see is that their failure-free survival, here biopsies were not mandated like in the cryo trials, but their failure-free survivals look really good, 88% failure-free survival and 98% metastasis-free survival at 5 years, with most of the bad outcomes, if not all the bad outcomes, happening in the Gleason 8 to 10 disease folks, which really I think are not good candidates for surveillance. They had excellent continence rates. They did not report on their erectile dysfunction, but they said it was tracked and will be reported on further. Once you've treated these men with some type of subtotal or focal therapy, how do you follow them? So MRI and PSA kinetics following subtotal glandular therapies are really not well validated. There's a lot of work to be done there. Some people for PSAs have used the Nader +2 definition as a way of having concern for biochemical recurrence following subtotal gland therapy. I think that for sure you have to advocate that you really will not understand what's going on with a person's cancer unless you do a biopsy to confirm that the treatment has occurred, and you have to biopsy the target you ablated, and also do the systematic biopsies. I think that since we want to learn more about the functionality of MRI in this setting, just like as we want to learn about the functionality of MRI after any treatment, including radiation, I think it's a good idea to try to get MRIs and target MRI targetable lesions. But really, the literature is sparse because not all the studies that have been reported required biopsies or required MRIs before that, and it's just an area of active study. So in summary, subtotal glandular therapy can provide for cancer control with limited morbidity in select men with stage 1 or 2 prostate cancers. So select men with, I think, high volume, low risk or favorable intermediate risk disease. The treatment remains, or this type of treatment remains investigational. The patients should understand that. We only really have short to intermediate term oncological outcomes data available. But they look promising in my opinion. I think that many men could be candidates for this, and I think you can preserve a lot of morbidity without putting them at substantial risk. The most important thing is going to be patient selection. I think that actually almost all research should really hone in on those areas. We have treatment modalities that have been around for a long time, like cryoablation, and for a fairly long time, like HIFU. And I don't think inventing a better tool is really going to be the answer as much as it is going to be being able to select patients in the best way possible, whether that be from better imaging modalities. We touched on PET MR maybe in this setting, or whether that be about how we go about our protocols for mapping the tumors before treatments, or if that's better understanding of things like, can there be genetic signals that are going to tell us who's going to fail at distant sites. But that's, I think, where we have to really focus in on. And then biopsies in follow-up are mandatory, are really mandatory in almost all cases. One question that brings up is how many different biopsies you need in follow-up to really say cure. I think probably the answer is around 2, one between 1 and 2 years, and the second about 5 years, and then you can follow PSA kinetics. So controversial area. I wanted to leave time for questions and discussion, and take those from the audience.
Ashley, this is Sean. That was a great talk. I'm curious. Number one, I'll just have one question. Why don't we solicit the help of our radiation oncologist to do focal gland therapy? I know, and is that something that's been studied or could be studied as relates to the different modalities?
It's a great question, and I think that there's actually a few questions to unpack in there. So one thing I think that is interesting. So one, there are some studies with focal brachy, but more so, there's been more studies using, or thinking about doing stereotactic radiation or maybe proton beam. I think there's a few considerations. So the first consideration is, I think that this type of therapy is best done when the therapy is ablative, and to that regard, I think that there are doses of radiation that you can start to deliver with some of the stereotactic radiation, and we'll have Dr. Sachdev maybe or others comment in a second, are getting towards that point. The second thing is, like, you don't really want scatter radiation, in my opinion. Like, I would not want to radiate, half of the gland or, a quadrant of a gland and have that scatter radiation then maybe affect the surrounding prostate tissue, because that might actually lead to a secondary intragland recurrence. So how can you get around that? Maybe proton therapy. There's some of our interventional radiologists here at Northwestern have recently published some animal studies using Y90 and an intra-arterial injection of Y90, which has very short range of penetrance past where it goes. Maybe that type of ablative study would be used for focal. But right now, what I would say is my hesitation is I don't want that scatter radiation to other pieces of the gland. and I don't, and that would be something that gives me a little bit of pause. If Dr. Sajdev is on, or Dr. Kalpurikal, or maybe Dr. Hartzell is on, or other of our radiation oncologists, I'd love to get your comments on that. And please, I know focal, I see Dr. Bugnose on, so maybe some of the comments from the radiation oncologists.
Dr. Ross?
Yeah.
Yeah, this is Jeff Ignatoff. I've got a question for you. So patient selection is paramount with this modality. It went through the genetic, some of the genetic exclusion. What about something like PIN in saturation or systematic biopsy before treatment? Should that be considered exclusionary?
So I think I understood your question. You were cutting in and out. Give me one, and it's a great question, Dr. Ignatoff. I'm going to answer it in 1 second. Before we go to there, do we have any rad-oncs that wanted to talk towards the radiation question before we go to that question? Because that's a great question. But, okay, then we'll go straight into that. I think, actually, this is something that, as I'm getting away from hemigland ablations, I think this is something that I'm much more enthusiastic about doing. Exactly your question, Dr. Ignatoff, because I think that because the MRI is undersampling or under showing you the lesion, I think that we may want to give strong consideration, and I'm moving towards this, of doing a second treatment planning biopsy prior to the focal therapy, where now I'm looking at the region of interest and mapping around the region of interest. So if I'm not going to do a saturation biopsy, at least doing a mapping biopsy around that region of interest. I think that one of the things that have helped that a lot is with these perineal biopsies in the clinic. So more recently, we started doing precision point, which, honestly, there's two things that happened when that was coming along in the clinic. One is they really started to understand how to anesthetize the prostate better. I mean, if you get into that, I think the best name I know for it is that space of Alloway, that under that endopelvic fascia, and you put lidocaine, particularly buffered with bicarb, in there, you can do 50 biopsies and the guy can tolerate it just fine. Retention is minimal, and so I think that gives us a lot of confidence to now do better sampling. The second thing I like about that approach is that I'm sampling in the same way I'm going to then do my focal therapy. So I haven't moved to that yet. I have to say, before I came to Northwestern, my focal therapies were all hemiablations. But now, as I've got more confident in the imaging, I'm moving towards doing these anterior tumors as quadrant ablations, or sparing the neurovascular bundle. And I think before I do that, to minimize in-field or inside recurrences, that is the best strategy. Are you performing focal yourself, or have you done it before?
Have I? Sorry, no. I've not.
Okay, but it's a great question. I think that's the way we're going, and I think that I think that a kind of another game changer to somewhat has been the ability to do kind of the ease of doing perineal biopsies in clinic without general anesthesia.
All right, it's Ricardo Suarez here.
Yes.
So right now you're doing cryo. Here, are you got plans to do other types of focal?
So, I don't. The reality is, I'm not sure. So, right now, cryoablation has a few things going for it. It's been around the longest. It has it's I think the least likely to have skip lesions, because you're expanding out of that ice ball. And it can treat the tumors in almost all the locations except for periurethral. The negatives about the cryoablation are, it's the least amenable, I think, to being, if there was a lot of active feedback for or robotics, or if you had some kind of thermometry feedback in the future, that is, you're going to have the computer do all the planning, like some of the HIFU is trying to get towards and already trying to make strides towards. It's the least amenable for that, but I don't know if that really matters, because if anything, you sort of want a larger treatment zone. And so then the question is, do I want to make or does Northwestern or another institution or another practice want to make a capital expenditure for something like HIFU or laser ablation, where there's no evidence that it ablates better? In most cases, I would say periurethral lesions might be an issue, but no evidence that it ablates better. And it definitely has a capital cost. The procedure may take longer. You wouldn't be able to transition it into like your clinic, for example. So right now I have no compelling plans right now. I think that the periurethral lesions are problematic in many settings. I think that for example, like HIFU can sometimes be an issue. Certainly, there's the Journal of Urology, they published the results of the Tulsa Pro, which is a periurethral HIFU that goes out, but that's protecting the urethra as well. I don't see a compelling reason for myself right now that I could make an argument to my chair or the Northwestern system to say we need to get a focal one or some other HIFU machine, and certainly not for laser. I have not been impressed with the laser data, and myself, I think it's mostly because the extent of infield recurrences due to them trying to get too focal. What do you think, Ricardo? I think I'd be interested to get your thoughts on this.
Well, when I was at UCL, they're kind of a protocol. If it is anterior, you do cryo. Posterior, you do HIFU. Apical, they tend to go more for brachy.
Yeah, and that's been talked about. In fact, in that one picture I showed, it was a review paper, is the same kind of a la carte thing, exactly what you were talking about. But the reality is, I don't know how true that is. I've done lots of cryoablations of apical tumors. As long as the urethra is, further away, it depends on what you define as apical. Definitely posterior tumors, there's no problem with cryoablation. I think there's no, you can get lots of space between the rectum and the, and the ice ball, and the one thing you would ask there is like, can HIFU sculpt better around the nerves? I don't know. So, I haven't, I have to kind of, I think that again, I have to get more sold to make the capital expenditure, or to kind of, for myself, I have to get more sold on those technologies. I still think if I could do one thing for myself for the next 2 years for focal therapy, it would be trying to do things that refine patient selection and making sure that we're having a better method of doing outcomes tracking.
Yeah, I have to be honest. I like your approach and the way the patient selection is done, because some people tend to try to broaden their selection criteria, and all of a sudden everything's focal, and then the recurrence is like 20-30% in field.
In field, and I think to that point, and this doesn't really, I mean, here nor there, but I think it's nice to have, I'm happy that for myself that I'm also a high volume, radical prostatectomy surgeon. So I think so basically it's nice to have a lot of tools in your toolbox, or a lot of partners like you guys to refer to for radicals as well, so that you're not trying to say, well, I think you got to really be careful about hammer and nail kind of mentality. So
yeah, but it's good. It's good. I'm glad you're doing that. That's great.
Dr. Ross, it's Brittany. I had a question in terms of, with these polygenic risk scores, would you ever foresee the situation, and I don't know if any of these labs are doing it, is doing like this polygenic risk score paired with some type of like somatic genetic testing for the biopsy samples that you're getting back for the patient?
Yeah, so there's 2 points there. One is, there are labs like that GoPath lab that I mentioned is they have, you can put in your tissue and they will do somatic sequencing, and they also will do the polygenic risk scores, and they'll do the rare pathogenic mutations as well. It's possible for the labs to actually try to sequence the benign glands, but they're usually sending in a blood sample with it. The thing is, like in my thoughts at least, it's kind of 2 separate things. Like I'm usually doing the somatic NGS. I'm usually, at least for myself, I'm usually doing it for the incurable cancers. So the guys that have certainly stage 4, but even stage 3, where I think they're going to progress through therapies, and I want to know what their options are. Do they, as you well know, do they have like, homologous recombination deficiencies? So if they progress far, they can have PARP inhibitors. Is there a clinical trial? Do they have things going on with their AKT P10 access, et cetera? For the guys that like, I want to get a polygenic risk score for something like, should they be a surveillance candidate? Should they be a focal therapy candidate? Those guys really, for me, are like the low favorable intermediate risk patients, maybe some unfavorable intermediate risk patients that are kind of older in age. And so in those situations, I'm usually not interested in what's going on at the NGS somatic mutation level, because there's just not a lot of mutations that are driving prostate cancer that are happening in that early stage, lower risk disease. Now, genomics, like things like the Decipher, genomic classifier, or like Polaris or whatever, that might be more rich. Now, they've looked before at not using those clinical grade tests, but just in some studies saying, is there a genomic signature that can predict multifocal disease? And they haven't found that. But right now, for myself, I would say they could. There are labs that do that. That are trying to do everything in one. I don't think it's really necessary for these lower risk people, but I do think that and I have actually started doing it for my higher risk surveillance patients and for my subtotal glandular patients. I am encouraging them to get a polygenic risk score, whether it be that genomic risk score from GoPath or others. And if it's high, I'm telling them that I'm have some consternation about going forward. Now we're going to be trying to study this. We're putting together a study here called ESPER, which is the expanded surveillance program for extended risk men. And ESPER is someone who has clairvoyance, and so that was the name of this multi-institutional study we want to try to start here. And we're going to try to integrate those genetics into that to see, like, do they actually portend more recurrences, et cetera. And we're hoping that that's going to be a multi-center study and maybe be the first arm of a cohort that will then serve, kind of like Stampede, as like a reference cohort when you have a new focal therapy or a new whole gland therapy. What I didn't mention here was beyond looking at this as non-interventional ways of treating these type of prostate cancers, there are studies that are going to report out, in the near future using things like Provenge or using some hormonal therapies like enzalutamide, and seeing if they can affect the same population. But back to your normal question, Brittany, I don't know if that answered or not to you. I think for this population, I don't know if it's necessary. Maybe something that combines their genomics or gene expression levels with their genetics would be great. But I think I'm going to advocate for, at least, and we're going to try to develop data for, is people who are high risk for surveillance or who are not going to have whole gland therapy. So you're going to leave that innate native prostate tissue in this person. I want to know if they have a polygenic risk score that's going to drive more cancers to develop. And these scores that are coming out of the PHS or that GRS score coming out of Practical and validated in the biobank, I mean, it's a quarter of those guys that are going to have like 4-fold increased risk. So I think that's sort of the next step for genetics.
Yeah, no, that definitely answers my question. Was just kind of curious how that played into your assessment for this particular population for stratification.
Those are great questions. I'm fine with finishing a little bit early. It looks like the weather's still like in the high 70s and the sun's not going to set for an hour or two. So hopefully everyone can go and enjoy that a little bit. Thanks everyone for your attention. Like I said, a lot of these therapies are also used in the salvage setting. I think something that like is not controversial at all, but often not implemented as well as it could be, is how we think about salvage treatment for after radiation failure. And we'll have a talk about that in August, and it'll focus on things like cryo and HIFU again, but in that salvage setting for that. So please stay tuned. Thanks, everyone. Have a great evening.